Okay, good evening, everyone. Welcome to tonight's meeting of the Health and Social Care Scrutiny Review Group. If I just do the admin stuff first, this meeting will be live streamed to the public. A recording of the public part of the meeting will be available on the council's website within 24 hours of the meeting. There is an item tonight that will be taken in private, so that will not apply to that item. Any remote participants joining online, if you can use the hands up icon for questions and comments, turn your camera on and microphone on when speaking and off when finished. Members and officers in the chamber, if you can remember, switch your microphone on when speaking and off when you have finished. Please switch off mobile phones or place on silent mode. Okay, apologies for absence.
None, Chair.
Minutes of the previous two meetings from the 15th of April. Those of you who were present at that meeting, are those minutes a fair and true reflection of the proceedings of that meeting? Yeah, thank you. And the 20th of May 2025. Okay, thank you. Any disclosures of interest?
None that I'm aware of, Chair.
The urgent business?
None, Chair.
References from committees and other bodies?
Again, none, Chair.
Okay. I have nothing to report on since the last meeting. Okay. Perhaps at this point, if we could go around the chamber and if everyone could introduce themselves, apart from the elected members. So anyone who's reporting this evening, starting at the front.
Mike Ward, EOC Transformation Lead, East of England Ambulance.
Neil Maloney, Chief Executive of the East of England Ambulance Service.
Evening, Mark Stanbridge, Head of Clinical Operations for Bedfordshire and Luton, East of England Ambulance.
Good evening, everyone. Matthew Hudson, Public Health Principal, here for the delivery plan for Healthy Weight.
Richard Assange, Public Health Manager for Healthy Weight and Food.
Good evening. I'm Elizabeth Elliott, Acting Director of Public Health.
Jo Jefferson, Integrated Commission Manager for Drugs and Alcohol for Luton.
Thank you. And anyone who's joining via Teams, if you could introduce yourselves. Okay. Thank you. Okay, if we could go straight into our first item, item number 7 on the agenda, ambulance handovers at Luton and Dunstable Hospital. If I could just, before you start, just to let everyone know, there's a couple of reasons why we're having this report this evening. First is obviously ambulance turnaround times are an important issue. The second is that the Trust reported to Bedford Council's Health Committee on this issue in November last year. And from the notes of that meeting, the comparison of the turnaround times between Bedford Hospital and the L&Ds stood out very starkly. So to quote from the proceedings of that meeting, between 1st January 2024 and 30 September 2024, the average handover time at Bedford Hospital was 17 minutes and 42 seconds, compared to the L&D, where the average handover time was 36 minutes and 14 seconds. So the average handover time at the L&D was double that at Bedford. So we've asked the East of England Ambulance Trust to come tonight and to report on the reasons for this discrepancy. Thank you.
Thank you very much. So we have submitted a paper which I think provides an update on that, and actually there is some really good news on progress that I think the whole system working together has made in seeking to reduce the ambulance handover times. across the region, actually, but actually specifically in this area as well. And I might bring Mark in just to talk a little bit about that. But I think what we have seen is very good engagement through the whole of the system. We have started to see those waiting times reducing. And if I can just give you some comparisons. So for the April 25 position, our average handover time for this area was 23 minutes and 3 seconds, whereas that compares to April 24 of 39 minutes and 55 seconds. So there is quite a significant difference there, which has enabled us then to put out more crews onto the road and more time that's out onto the road. And we have seen our category 2 waiting times for those patients that need immediate response, a reduction in our waiting times of 8 minutes and 37 seconds, which is down now to a 30 minutes and 12 seconds, which is in line with our national target. So there's a national target of 30 minutes. It's now very, very close to that, which is a significant improvement on last year. And we've also seen our category 3 waiting times now reducing as a result of that. But I don't know, Mark, whether you wanted to bring any more out from that.
Lovely, thank you, Neil. So I think it's really from previous meetings we've been at, we've discussed about the hospital handover at 45 minutes. So ourselves, ICB and the acute colleagues, both at Bedford and Luton, have engaged really well, actively, positively, and linking in with Kathy from Bedfordshire Hospitals, who's the Chief Operating Officer. We've been had some real fruitful, positive conversations, and to be able to deliver sort of the ask really. So the time that Neil has just discussed from most recent in April, coming down to 23 minutes versus the 39 minutes, I think is testimony to the engagement with the hospitals, with ourselves and with the ICB, bringing us much closer to Bedford. I suppose coupled with that, not only are we then putting out the ambulance crews quicker, as working with system partners, ICB, we've got a couple of other things that have taken place. So we've got our Unscheduled Care Hub Coordination Centre, and that looks at some of our hear and treat functions and actually the lower acuity calls and passing them out to our community providers. So that isn't sending an ambulance response to an individual, but actually getting the right care to that individual via a telephone method to start with as a triage, and then also sending out community teams to those individuals. I suppose looking at the paper that we have submitted, if we have a look to how we have done, looking at into April, just shy of 300 calls were accepted by the UCCH and they were completed. So that stopped 300 ambulances, or 299 to be precise, arriving at somebody's front door with the potential of taking those individuals to the hospital. So just shy of 300 patients received care in the community and not attending the A&E departments. Of course, that's relieving the pressure within the A&E departments, which is fantastic to see. Secondly, we've also got a conveyance avoidance helpline, and what that is, if we've missed the first point of contact with the lower acuity call and we have sent an ambulance to that address, our clinicians are now able to make contact from the 10th of March to a doctor on the phone, to have those clinical discussions to say, this is what I'm presented with, and actually I don't believe this individual needs to go to hospital, and they're having consultant support to say, actually, you are right, this individual could be treated within the home environment, and therefore that then stops individuals attending the A&E departments, filling the A&E departments and hospitals up, reducing conveyance, and therefore providing that care within the community. So I think with those actions, the positive engagement with the hospitals, the implementation of our UCCH, the implementation of our conveyance avoidance helpline has given us a real rigid and great platform to actually get treatment to individuals within our communities at their home environment with follow-ups with GPs. So actually we've had some real great engagement, and testimony to that, we've then obviously seen a reduction in our hospital handovers and also an improvement in our C2 and C3 response times.
So we've certainly seen some considerable improvement and really good engagement locally, which I think we'd really welcome. And it's meant that, you know, we're then able to direct the resource that we've had in terms of getting out to those patients and reducing the waiting times for those patients in the community. Chair, with your agreement, one of the other things that we had included in the report to the committee was also an update on the Bedford EOC, the Emergency Operations Centre. And I just wonder whether it might be helpful for us to just give an update on that, because since we were last at the committee, the board, the East of England Ambulance Service Trust Board has concluded that we should move from the current 3 emergency operations centres down to 2. And that means, I mean, for a number of reasons. Firstly, that none of those sites are currently meeting the standards that we would expect of an emergency operations centre. And in order,
Sorry, no, can I stop you there? Can we can you take any questions about first pass the report?
Sure, very happy
then
to do that.
Go on to the emergency centres. Yep, thank you. Okay, does anyone have any questions on the first pass the report? Councillor Ahmed, then Councillor Singh.
Thank you, Chair. Although you have already briefed about the handovers, is there any more that being done to speed up these handovers so ambulances can respond faster to other emergencies in Luton?
Lovely, thank you. So the continued engagement with the local hospitals, we've obviously got different estates. So Bedford Hospital is very different to Luton Hospital. So actually the estates can cause some delays. With the engagement with the hospital, we are looking to streamline processes slightly further. Luton and Dunstable have had a new rapid assessment unit that's opened. So actually we are able to bring patients straight into the department, hand over to the nursing staff, book the patient in a very streamline approach. There's of course everything we can expedite in speed. However, at the moment it is probably one of the quickest it has been for a long time. And actually we are still engaging with the hospital. We have one of our band 7 hospital ambulance liaison officers down there, or whether we have a leading operational manager, because we've had a change in some names within the organisation to expedite some of the process. So it's going to be the continued engagement, learning from any processes. So we do have regular contact with the hospitals to discuss the process there.
If I could also just briefly come back to that, because I think the ambulance service has a very specific role in supporting the whole of the system to try and ensure that we're not placing any pressure onto the acute hospitals. And that means working with other community providers to enable us to manage those patients out in the community where it makes sense to do so, so that we're not just conveying patients into hospital. Working alongside with our 111 providers as well to ensure that they can manage some of that demand for those relatively minor patients, that they can then utilise some of the clinical expertise that they have. We're working with commissioners at the moment to try and support those patients to be managed within 111 to enable us to then focus on those patients that we really need to see.
Councillor Hussain.
Yeah, can I ask you in terms of, you said that in terms of L&D there has been a major improvement as far as that, and Bedford was already on the way to improvement. Now my question really is that you just mentioned, you know, that where we have other partners where we can do that to be able to send people or so how would you see the improvements in the longer run, so that people can get the most urgent cases, improvement and services, where somebody who may not be probably dying, but fallen into a bathroom, a 90 years elderly person, I know that because I had to go and get neighbors to get him out of that. Yeah. So, you know, even though it's not an emergency, in 90 minutes, nobody turned up. So for that person, it is an emergency because he's in this huge amount of pain and discomfort.
I'll perhaps start with that and I'll bring in Mark. So, you know, we know that some of our waiting times recently, largely because of quite a significant increase in demand that we've seen over the last few years, has meant that our waiting times have been higher than we would have liked. We have been working very hard to look at the 3 key areas, and that is, first of all, trying to manage many of those patients out into the community so that, frankly, we're not putting any additional pressure, as I've mentioned, onto the acute hospitals, and working with community partners to manage the demand in that way, but also looking at, and I think Mark made some reference to this, to be able to talk to patients over the phone. So many of those patients, actually, they don't even need an ambulance to be sent out in the first place. So how can we have a conversation with them and ensure that they're then directed to the best possible service right first time? The second thing is to ensure that our services are as efficient as possible. And we're spending quite a lot of time internally looking at how we can redirect the resource into the right places that would enable us to ensure that we're meeting the commitments that we've made to patients in reducing those waiting times. We've got some significantly ambitious plans for this year to substantially reduce those waiting times for patients. And the good news is that we're tracking against the plans that we've now agreed with NHS England, which is really encouraging. And then the third element of that is ensuring that we're working with those organisations where we do have to go and see those patients, and it's right that we then convey them into hospital, is that they then have sufficient capacity to be able to accommodate those patients, and that we've got flow throughout the whole system. And of course, what they will say is that that relies on other community partners as well, both in terms of social care and for those patients that then need to be discharged into the community, having the right support for them to be able to do that. Because if they don't, then what tends to happen is that then backs up into the A&E department, and sadly, in some cases, even into the ambulance. And we saw some very substantial delays over this winter with a whole range of additional things, not least the flu pandemic that came at right at the time in which we typically do have significant pressure on services. But the good news is, as I've said, we've seen some tremendous improvement in that performance over the last few months, and it's encouraging to see that all of those elements are now making a real difference.
Thank you.
Okay, anyone else? Any questions or comments? I have a few questions. We're talking about the unscheduled care coordination hub and the conveyance avoidance helpline. And can you assign the improvement in response time in handover times specifically to those two improvements? Can you say that the 16 minutes improvement is completely down to the UCCH and to the avoidance helpline, or is there anything else that's at play here?
So there are a number of things that go into this, and certainly managing urgent and emergency care over the many years that I have, I've identified that, the range of different solutions that then come together is very difficult to pinpoint one particular scheme. What we do have is some key schemes that are in place that are enabling us to manage demand much better. So the UCCH is a really good example of that. And the call before you convey the avoidance helpline is really enabling us to manage that demand very much more significantly. But also we have seen quite a substantial increase in the what we call the hearing tree rates. So those are our staff that are dedicated and working in our emergency operations centre that are engaging with patients and are looking to navigate those patients to the right service. So it doesn't necessarily mean that they need to go into hospital or to have an ambulance crew go out and see them in the first instance. So we're spending a lot of time trying to manage some of that demand, but also we are also seeking to address some of the handover times through the actions that we're taking in the hospitals themselves. And that's managing the flow throughout the hospital better. So the hospitals are taking responsibility for that. But the interaction that the ambulance service has with the hospital as well is also making a difference. So our engagement with them and our ability to be able to hand over those patients as quickly as possible. So we've established a standard operating procedure now for ensuring that we have a maximum waiting time of 45 minutes. Now, there are some occasions where patients will go beyond that, but actually there's been significant improvement in the number of patients that are now being handed over within that maximum waiting time.
Okay, these improvements, so the figures that you've quoted in the report is comparing April this year with April last year. Do you anticipate that the improvements and the schemes that you're implementing and carrying out that they will be able to deal with, for example, next winter's potential flu crisis next winter?
So invariably, we do get an increase in activity during the winter period, and we're actually in the process at the moment of finalising our winter plan. So we're anticipating that will conclude certainly by the end of August, so that we'll have a really clear understanding about the actions that we need to take, and then the support that we're going to need from whole system partners in enabling us to manage some of that demand over the winter period. Now, that also means that we're going to need to put in additional resource over that period, and we're certainly anticipating this year that we will see a substantial improvement on our performance compared to the winter that's just gone as a result of the plans that we're implementing.
Okay, thank you. If there's nothing else, if you'd like to carry on with the emergency centres part of the report.
Thank you. So as I mentioned, the board considered the number of emergency operations centres that we needed to have. So this follows on from the decision that doing nothing was just not going to be feasible. And in order for us to be able to make these sites ready, we would have, on the Bedford site, would have needed to invested £3.5 million just to upgrade the existing facilities. But one of the issues that we needed to address was to ensure that we were able to be resilient across the three sites. And if one of those sites went down, it would be very difficult for us to be able to accommodate the increase in demand that we would have on those individual sites. So we needed to have an alternative site for those areas. So the decision that we've taken is to, partly because of some of the investment that has already been made on the site up in Norwich. We had two other sites, the Chelmsford and the Bedford sites, and the plan is to close both of those sites. But then we've then agreed to move to a two-centre site, because that enables us, apart from anything else, to improve the resilience on those sites and ensure consistency and approach on all of the emergency operations centres. The impact of that will not have any impact on patients. We've certainly been working that through, and then we'll ensure that there is consistent resilience in all of the transition to a two-site option. That the plan would be, in deciding which site that should be placed on, we looked at three key things, one of which is how many staff would be affected if we were to move to a two-site option. There were 103 staff on the Bedford site, and we had 196 staff that would have been affected on the Chelmsford site. So there's the decision that the board has taken to effectively move to a two-site option and to centralise that in an Essex site, most likely to be in the Chelmsford area, so that it affects the fewest number of staff. As I've said, I'm not anticipating that there will be any significant impact on patients. And if anything, this will give us a return on that investment, if you like, of reducing down to two sites of 1.2 million per year, that we will then be investing in additional ambulance crews that will help to support us in the delivery of a reduced waiting time for our patients out in the community. Perhaps if I pause there and we can take any questions.
Thank you. Okay, yep. Councillor Begum.
Thank you for the report. I did have a question, but you kind of just answered it about the staff job being affected, which you answered already. There's few things I want to make comment on, and then I will ask my questions. Okay, so the first one is I've got a few concerns that there is no, on the report, there is no record of any engagement with any residents. Either Bedford or Luton or whole of Bedfordshire, there is no plans to communicate to them about the changes. I know there is in there about the MPs being involved, but the residents are not being involved. I didn't see any community groups being involved. There's no details on potential impact of these changes on the residents. I didn't see that in there. So my notes are quite scribbled, so I'm going to see what I have said in there. No details on potential impact on residents, emergency services, access beyond the response time. There is no timeline of staff well-being and the support during the change. there is okay, you said there is a response time improvement, but there is no details on risk for closing the Bedford EOC. Okay, so those are my comments. So if I can ask my questions now, cheers. Okay. So I think you answered the first one about the jobs, how many jobs, you've answered that, but there isn't a detailed plan on the relocation of those staffs or redeployment or their well-being, the staff's well-being. I have a few questions if I ask one at a time. Is that okay? Yeah.
Yeah, so perhaps if I just address some of the comments as well as part of that, because I think that's important. So just in terms of the engagement, we're not proposing any changes to the service that we're providing to patients at all, right? So we will ensure consistency. So if you like, these are teams that are based behind the scenes, and it really doesn't matter where you place them across the whole region. What we are going to do, in fact, is that far from reducing the number of call handlers that will be taking those calls, is that the plan in our plan for this year is to increase that by quite a substantial number, so that actually we are able to not only continue to deliver the really good performance that we have at the moment for call pickup time, but to ensure that we sustain that even over the peak of winter periods. We know that particularly where waiting times have increased over the winter period, we do have an increase in the number of calls because some people do bring us back, and that increases the calls, not only the number of calls that would come in the first place, but those repeat callers as well. So we need to ensure that we're resilient for that, and that's why we're investing in that service. So to that extent, there's no need to consult with the public because we're not anticipating any impact. We are transitioning into the Chelmsford area, and we clearly are. We do have a very detailed risk assessment and a plan to ensure that is a successful transition. In terms of time frame, that will be managed over the next 18 months. We're anticipating that will take us about 18 months to do that, and there's a huge amount of support that we're providing to those staff that would be affected. In fact, we're working with other public agencies to look at some of the options that would be available. So, for example, there is a 111 service that we're looking to see whether any of the staff are interested in that. But actually also, this is a very important entry point into the organisation for those of our staff who want to go and work on the front line. And so we've committed to ensuring that any that wish to retrain and go and work in an ambulance, for example, that we'd be very happy to help and support them through that process. But we're also working with other agencies, so fire services, and there's a local housing association as well that is also looking at staff to potentially transition across to there. So we'll work with all of those staff to help them into moving into the right place. And of course, any of those staff that wish to move into the Chelmsford hub, then we will then support them to do that.
Thank you. I mean, I do appreciate that there is no effect on the services, but once this gets out and the residents who know Bedford is closing, they are not going to see it like me and you will see it. They are going to say, okay, it's going to close. We are affected. Why don't we know about it? So that's one of the reasons why I said is giving them the information beforehand that it's not going to affect them in any way.
So we're certainly releasing that information into the public domain. It's been heavily covered in all of the newspapers already. And this has, we've been very clear that we're going to be very open with our staff right at the beginning part of this process, and inevitably that has sifted out into the public domain. So I believe that is already out in the public domain, and we have as a result of that also been engaging with stakeholders in terms of some of the key elements that they will want to ensure is in place in order to ensure that there is no impact on patients. And also for those residents in these areas, we want to ensure that there is an alternative for those staff so that they can be retained in those areas. Incidentally, what I should say is that the plan is to continue to keep that site open so that we will look to help to facilitate other services to move into that site.
Thank you. I think most of my questions are around residents' engagement, but you kind of explained it. So this is a question for the trust actually. How will the trust monitor and respond to concerns from residents if there is any that you get, and will their feedback be taken on board?
Very much so. And in fact, all of the comments that have been fed to us were certainly fed into the board decisions. So that was represented in the board, any of those external concerns. It perhaps comes as no surprise that there was a huge level of interest in this from the unions in the ambulance service. And we took all of their representations into the board meeting and had considered that as part of our decision making.
Thank you. And I assume the trust governors would have been involved in that one?
We're not a foundation trust, so we don't have governors in the organisation. Yeah.
It do.
Foundation trusts do, but not NHS trusts.
Okay. Okay. Sorry, I'm getting confused between, because I do understand there is a governors in there. I'm sorry, I'm getting confused maybe.
So we do have a community engagement team that we have been ensuring that we're keeping them up to date, and they certainly help us with that, some of that local engagement with our partners as well.
Thank you. Thank you, Chair.
Thank you. Councillor Hussain.
Yeah. Can I ask you literally two questions, and I'll put them both together. Firstly, you said there will be an improvement in service. I mean, you've got a very experienced people working at each site for many, many years who have a huge experience. So if they are not moving, will there be any redundancies in that? Have you, in terms of that? And you said you have consulted with the unions and in terms of that. My serious concern is that would that, experienced people, would they be encouraged to, go to the new site so that, they even know literally the area that they have covered for many years?
Perhaps if I start, then I might hand over to my colleague, Mike Ward, who can just talk a little bit about some of the work that we will be doing to ensure that we've got a resilient plan to manage that. I mean, the first thing to say is that this is going to take us some time to do that. We're finalising discussions on a particular site, and that will require us to also make that site ready, and that's going to take a number of months before we can do that, which is why we're anticipating that this will be over an 18-month period. It's clear that there will be some staff that will leave within that time period, and we've made arrangements to ensure that our recruitment plans accommodate the anticipated number of staff that are likely to leave between now and then. We will have some very experienced staff that are in there, and we're actively encouraging them that should they wish to move over to the new site that they can do so. But I recognise that that's not going to be right for every member of staff. There is some distance between the sites, and I suspect some of them will not wish to transition into the new site. But what we will have is a plan that will enable us to recruit and then also to ensure that we've trained those staff, not only in the requirement to pick up the calls, but in the important, so if I just explain that there are two elements of this that are going to be affected. The first one is to pick up the call. It doesn't matter where you are in the country when you do that. We have an arrangement in place where there are organisations across the country, so other ambulance services, that in extremis they can help and support and even pick up those calls. Once it's determined that that patient requires an ambulance, they're then handed over to the dispatch team, and then they make decisions. And that, again, it doesn't matter where you are within the east of England. We regularly do have some support from other parts of the region where they're able to allocate an ambulance to that particular crew based on where the caller is. And we have a geographical information system that enables us to highlight where our crews are and where the caller is. Mike, I don't know whether you want to say anything else on that.
Thank you, Neil. Yeah, so as Neil's mentioned, so the technology supports our effectiveness as an organisation and supports our call handlers, dispatchers and clinicians within the control room to ensure that we get the right resource to the right patient. So alongside call handling, our system also supports our dispatchers to identify the nearest suitable resource to be able to send to the patient. And that can be done anywhere across the region. And we do that because it maintains our resilience. So it'd be very difficult for us to be able to have members of staff in our control rooms that only really work in the area that they're familiar with. Geographically across the region, that would be very difficult for us to achieve, and it would make us less resilient as an organisation. So our technology supports the effective, speedy resource dispatch within our control rooms. And in terms of our transition, we will transition over time, as we've mentioned. So we will start to build our resource in the right area before we need to make a decision at which point Bedford would cease to operate. And as Neil said, we're absolutely looking to support people to stay with us as an organisation.
The reason I said that was that my late friend, fallen in his house, couldn't make a call, just pressed a button. But I experienced person who answered managed to get the fire service first, and then the ambulance arrived, saved his life, but he later obviously passed away. But that was, a huge, how they immediately identified his address because of his mobile phone and all that. I thought that was fantastic response.
It perhaps might also be helpful to highlight that currently we're meeting all of the national standards at the moment for call pickup time. There was a point about 6 months ago where that wasn't the case, but we've invested in that team. We currently have about 90 members of staff that are there across the the trust to be able. Sorry, I beg your pardon. That's the increase in the staffing that we're looking to put into our emergency operations centres overall. But there is clearly an increase in the overall number of call handlers as well that would enable us to meet the requirements to consistently achieve that standard. So we are actively recruiting now, and in order for us to be able to meet that requirement.
Councillor Moore.
I just wanted some clarification. I'm understanding what you're saying on one of those points the way I think I'm meant to be understanding it. So what you're saying is when you have the technology that when the call comes in, they don't need to ask any details about where that call's coming from. They can see that, and they can see that because obviously the first thing I look at when I'm looking at this is you're not going to have anyone from 2 hours of a site inside Luton or Bedfordshire working at these places, because I played cricket in Chelmsford, I've been to Norwich. I wouldn't commute to either of those places from anywhere around there. So that would always have been my problem. But the way I'm understanding what you're saying is that those details are on the screen for them. Before that, I don't need to get any details from the caller.
So when a patient rings up any of the call centres, they will go through a script, and it's irrelevant to where that patient is calling from or that caller is calling from. So it wouldn't be unusual for us to even help out some other ambulance services, and that caller could be coming from anywhere across the country when there are times of peak pressure, and there are some calls which we do receive. It's a very standard script that we go through, and once we've then determined that patient then requires an ambulance, we will then send that to the local dispatch team for them to then be able to allocate that ambulance. And what they will see is, if you like, a system, a geographical information system that will enable them to see where the local resources are and how we can then allocate that resource out to them. And that you don't need to be in Bedford in order for you to be able to do that.
Thanks. That's how I understood it. Thanks.
Okay, thank you. Anyone else? Okay. Right. I haven't got anything to add on the second part of your report. I think we've gone through all the issues and arguments and the points about that on a number of occasions. So I think, yeah. So I mean, everyone is aware of the issues involved and the potential effect on the staff at the Bedford Centre. Going back to the first part of the report, it's obviously very encouraging that all the targets are now being met, and that it's also good to hear that one of the reasons, or the main reason for this, is the cooperation between the different parts of the health service. So yeah, thank you for your report, and thank you for coming here tonight. It is appreciated that you turned up here tonight to give the report. Thank you. Okay, so if we go on to the next item on the agenda, item number 8, the delivery plan for healthy weights.
Right, thank you, Chair. Yes, so no presentation for you guys this evening. So we've supplied the report. There is quite extensive documents in there, so apologies for that, but hopefully they're being really insightful. I'll just do a brief introduction to it, Chair, and then open to questions if that's okay. Thank you. So as demonstrated within the delivery plan, overweight and obesity remains a local and national public health priority for everyone. Previous guidance and behaviour change approaches has placed a lot of emphasis on the individual or the family in terms of changing their behaviour. However, this has changed, and that was largely driven by an update to the NICE guidance in January of this year. This delivery plan clearly demonstrates focusing solely on behaviour of the individual or the family will not lead to long-term sustainable change at a population level. So we must ensure we and our partners, our stakeholders, are contributing to those building blocks of health so we can deliver a health equity town. In terms of what's different and what will change as part of this delivery plan, this plan aligns us with national best practice underneath the Healthy Weight Declaration. And that provides us with a framework and an opportunity for us to re-announce our intent about this health issue and for us to have more flexibility and autonomy around how we deliver and support our residents. It enables us to be braver in our approach, to try new things, and to be innovative in our approach in terms of looking at digital and technology and other ways in which we can support our residents, so we can celebrate our successes and we can learn at a faster rate in terms of how we can best tackle this issue. In the Appendix A of the executive summary, I hope you guys have noticed the call to action, which sets out our expectations of different areas, particularly within the council. This stresses the importance of system leadership, but equally in recognising that we can't do this on our own. This is something where we need a system approach. And as we continue with those expectations which we've laid out, we will further develop and enhance our action plan, which is within the document. So ultimately, it's recommended that Scrutiny endorse the adoption of the delivery plan and commit to supporting its delivery as we move forward. Thank you, Chair.
Thank you. Okay. Yep, Councillor Hussain.
I've got a couple of questions, and if I can take it by first one. I mean, first of all, thank you. Very comprehensive report. There's lots of figures given in it. But one of the things that I have not understood really is year 6, the health of the children, particularly, far worse than any other part of the town. And well above the national as well as regional average. Do you know why? Is there any particular reason?
Sorry, Kath, just for clarity, is that why there's such an issue with year 6 in terms of prevalence? Was that what you were asking? Or was it about individual locations within the town?
Yeah, but you were saying further down on page 117, in terms of the takeaways and all that, the largest number of takeaways happened to be in the south and Biscuit. Yet their figures are not as bad as Farley. Farley's got no more than 3 or 4 takeaways, right? And in terms of the free school meal, the other 2 wards, Dallow and Biscuit, and the South Ward is higher than Farley. So what is the reasoning for that to be standing out well above the other areas?
Yeah. Thank you, Councillor, for that question. So as you rightly allude to, that's generally, I mean, in terms of the prevalence and abundance of hot food takeaways, particularly what we see in Luton, obviously accessibility to those is much easier now with the likes of Deliveroo and other apps and things. So in terms of having abundance in an area, it doesn't always necessarily correlate to where we might see a higher prevalence. I think the other thing just to be noteworthy of is when we look at the obesity data, particularly from an NCMP perspective, it's cohort dependent. So one cohort this year may be really high in one school or one area, and then the following year it may be lower. So in in essence, we generally try to focus on the 3-year combined data, which will give us a bit of a clearer indication of where we're seeing sustained prevalence. And equally, as you say, where free school meal allowance and things and that's are as well. Although we do know that deprivation does correlate to the prevalence of overweight and obesity, we know that that's true. Equally, like I say, in terms of that cohort balance, sometimes it's just slightly different, where certain cohorts may have a higher prevalence of overweight and obesity than others. So there is a bit of skewing to the data sometimes when we look at just the cohort years. But as you rightly point out, we do know those issues do correlate to a higher prevalence of overweight and obesity. So as the plan illustrates, it requires multiple effort across multiple different areas to ensure that we're having that impact. But even looking at schools, and one of our intentions as part of this plan is to do a school food audit to understand the nutritional content of the food, how schools are abiding with local policies around food and access to takeaways, particularly when we're looking at the academies and secondary school provision and what's permitted within those areas. So there's much more for us to understand in terms of how it's all coming together and influencing it. But what we do know is it's those social determinants of health which are creating that obesogenic environment, and that's where we need to start to refocus our efforts and our resources into that, as well as providing that individual behavioural support through total wellbeing, for example. We do need to start doing a bit more around how we're changing our environment and where we live. And the local plan refresh is a great example of how we're working much closer with planning officers than what we have in the past as we're going through that. And equally with education and social care, how we continue to build on those relationships as part of the adoption of this plan. I hope that's helped.
Yeah, because when you read further down, but at a very early age, when they're babies, the Henry program was very successful, and those children started out very well. And as they grow slightly older, it's getting worse. So that's what I'm trying to get at is that deprivation or children living below poverty has grown in the last 10 years. In fact, since the COVID, in Fali has gone to nearly 72% children living below poverty, which is a disgrace with the 6th richest nation in the country. So that to me is a serious concern. And what we as a public health body and the local authority can do in terms of that bit, where we can target resources, which is the worst area of the town. And my other question with it would be, is that anything to do with the ethnicity of the children? Or is it just a general thing, certain areas in the town? Because Birmingham and Barnfields is totally different. The figures are very low in the child obesity.
Yes, Councillor, certainly ethnicity plays its role as well. I mean, particularly in the data we see a particular high prevalence for year 6 data anyways, in young black boys, for example, we see a high prevalence within that ethnicity group. So as you say, there are cultural things as well at play which we need to consider, but naturally just Luton by its geography in terms of open space and access to open space and being quite an urbanised town, we're seeing those opportunities, saying like where we have the policy around play streets, for example, where we're trying to unlock other opportunities for people to be active and get out and play. But I think rightly, as you say, again, we see at reception data, we're performing better than the national average. So a lot of the fantastic work that goes in the Early Years Alliance, Family Hubs, all the work with CCS that we're doing in the early stages is really helping. But as we see either children gaining more independence around food and decisions they're making, or being able to influence parents in terms of that. So that's one aspect. In terms of activity levels, we're seeing that reduce. And, in terms of children who are participating and enjoying. So one of Sport England's main priorities is to ensure that children are enjoying participation, sport, physical activity. The culture within schools, within families, within different cultures and ethnicities around sport, physical activity and participation, and how that's important in terms of helping with this issue. But fundamentally, I say, as you rightly say, as the children get older, whether parents go back to work, it's the environment in which they are living in which is causing this prevalence in overweight and obesity. And until we start targeting or having more of an impact on those deeply entrenched health inequalities which exist for a number of different reasons, including protected characteristics, we're not going to have the impact we want. We're just going to keep scratching, trying to pull those people out of the river down the stream. We really need to get that focus back upstream and focus on Health Equity Town and how we can make that a reality and how we deliver Luton 2014. This plan is really looking at how, from a weight perspective, we make that change in everything that we do is helping to deliver that health equity. So when we engage with families, what other support services can we signpost them to? Do we even need to discuss weight with them at that time, or is there more of an appropriate conversation around looking at Luton supporting you, for example? Are they getting the right amount of support at the right time? Are they aware of the support which is available to them? As an example, it's how we're ensuring all those steps are in place. So as my colleague Shamami would say, the causes of the causes, if we're tackling those, then that will help us deliver the outcomes that we need to achieve in terms of reducing overweight and obesity prevalence.
Can I ask you, at the next report in a few months' time, I think we would like to see, the areas that are the worst. What are we as a public health statutory body doing about it? And how are we're talking not only physical activity, but other initiatives. In some of the towns where there is a serious problem, they have restricted any new takeaways, right? So, the reality of life is town centre and biscuit, you're not going to change it because they are there and, they continue to be there. We can't close them down. But we need to be taking that seriously, particularly where there is a fast food place opening near the schools. And that, a number of local authorities have put a restriction because of the public health has objected. Yeah, nothing in the 500 meters from the school. So can we really, look from you coming back to us and giving us some positive initiatives which would make the difference? Yeah, and the reason I ask you for the ethnicity is there some area, there's a large Asian and Black community. Farley has got a lot of white community, white working class. So we need to be seeing, well, what is it that is happening in that particular area and not somewhere else? Sam is, Barnfield is, exactly the same. And Brahman is predominantly white. So why one part of the town? I know they are middle class, obviously, so I do understand that difference between Farley's working class, council estate, was council, still a large council estate. And we please get that sort of thing back to us so we can appreciate that, this is something that local authority is doing.
Yeah, absolutely, Councillor. Be more than happy to come back and show a report around what we're doing, what our plans are, and how the board can support us.
Thank you. Councillor Begum.
Thank you, Chair. Thank you, Matt, for the report. Good to see about MEC in there and the community hubs. I think community food growing hubs is very good initiative. In my ward currently there is a Gurdwara on Cardigan Street, and they do the cook and eat. So Equality PCN from one of the surgeries, they get together and they provide services people to come and cook and eat. So it's healthy food options. So those initiatives are very important, I think. I do agree with my colleague. It would be good to see ward level, which ward is the most, has, according to NCMP, the data, which ward is most affected or has the highest obesity rate. That would be really good to have. And I do this at every report. Is for me, the important bit is residents' engagement. For this one, have they been asked about it? Have they been engaged? Have they been engaged directly? What do they need the most? asking them what do they need the most in support with, are these being met, what are their barriers, is it cultural, is it stigma, or accessibility, is it language, what is it? So it's asking those questions, and have we engaged with residents? That's what we need to look at. The questions I have is, do we have a person leading this, and like a coordinator or someone, and how will the KPIs be monitored? So 2-in-1 question.
Yeah, no problem. Thank you, Councillor. Absolutely. I think in the needs assessment, I can't recall. Just going to ask. I think we go down to ward level in there, don't we? Yes. Yeah. So in the needs assessment, if you review in there, I can't remember what table it is, but we do go down to ward level in there in terms of prevalence. Yeah. So we've got the heat map in there, and